So, a very good evening to all our Physio TV viewers. Today, we are going to have another episode of The Road Less Traveled. As we know that we kind of interview noteworthy and distinguished therapists or therapists from who have kind of taken a road less traveled and have ventured into different places and done different things so that all the young budding therapists or all of us out there who are practicing can kind of learn from their experience in some way or the other. Today, we are having a very interesting therapist who is an alumni from the same college that I did my graduation. That's Sage GS Medical College and KEM Hospital in Mumbai. So let me go ahead and introduce Dr. Gayatri Desai Mathur. Dr. Mathur or Dr. Gayatri is a social entrepreneur and a physical therapist with over 3 decades of experience. She's trained in GS in Mumbai and has got her advanced masters at University of Iowa and a doctorate at Mass General in Boston. She's been a clinician, a professor, a researcher at some of the world's leading institutions such as Northwestern University, University of Sydney, at Shirley Ryan Ability Lab, which is perhaps the #1 rehab hospital in the US for the past 30 years. She has many publications in the top international and peer-reviewed journals. And most recently, she is the founder and CEO of a non-profit organization called Sundar Foundation. So I invite you, Dr. Gayatri, for this very interesting talk on road less traveled.
Thank you so much, Sona. It is such a pleasure to be with you. It was really wonderful to hear from you, as you said, as an alumnus of GS Medical College. It was great to hear from somebody who had, the same experience as I did, and we began from the same place. So thank you very much for this opportunity, Sona.
Yes. So at the very beginning, I think just give us 2 minutes and we'll kind of want to share this journey. Yeah. So yes, let's start from the very beginning then. All right. So I guess this photograph kind of puts or some of the experience that you have, I mean, in GS, and I can see almost a whole batch and maybe more in this picture where y'all are all together. So can you how did you get into physiotherapy?
Yeah, I got into physiotherapy the usual way. I, got the marks to do that. And I was very excited to meet this group of people. We had a fabulous time together. I still remember all those years extremely fondly. Many of these people are still my very, very close friends. And we still are on, WhatsApp like everybody else. We have had a few reunions.
Oh, wow.
So it's been really lovely to have all these, folks who were with me initially at the journey still along with me for the ride as friends. It was, I feel I had a really phenomenal educational experience at GS. We had to pull a lot of information for ourselves, but the grounding that we got in all areas that we needed to learn as physios was just so solid that when I started practice, I was, like all my peers, felt very confident of the things that we were seeing. We felt we knew what to do or knew whom to approach to discuss complex cases. So that was really a very, wonderful beginning for me personally anyway, and of course, college is just the best time of your life. So it was really a great experience to springboard to the next level, which was to come to America on a full scholarship. And I felt that I was very well prepared. Okay. I was extremely prepared. I saw, there were so many things that were so easy because of the volume of people that we see in India. The different conditions and the clinical judgment develops very quickly because you see so much. The one area that I hadn't had much exposure to at that time was research. And my degree was essentially a research degree. So that really opened up my mind in ways that I did not anticipate, because It's a whole different way of looking at our profession and the world, actually. So that was really very exciting, very creative, very innovative for me. There was, and of course, I went to the University of Iowa from Mumbai.
Mm-hmm.
Iowa is in the Midwest, and these polar winds blow through in the wintertime, and it is, minus, I don't even know what in Celsius now, I'm forgetting. It's probably in the minus 20s. It is really, really cold out there. But when you're young, you buy a big fat coat and it doesn't matter. At least it didn't to me at all. I was having so much fun. I met so many new people. And as I said, professionally, it was a complete sort of awakening on a different, um, aspect of looking at my profession. So it was a very exciting time. And from there, I started working, which was, also a huge, wonderful experience, because when I left India, there were not very many total hips and total knees. In fact, the very first knee that I saw was at the University of Iowa. The first total hip and the total knee that I treated and even saw was at the hospital at University of Iowa Hospital. So there was a lot of learning also from the clinical aspect, and I enjoyed interacting with patients. And a lot of my colleagues who were from Mumbai and were from India, will also share that when we come here, you interact with patients on such a one-to-one basis that you learn so much from them. It doesn't take time to integrate. Interact with them on a very personal level, because you're talking about functional things and how far is your mailbox, how far do you have to walk, what do you need to do in your home for you to resume your function. So getting all those sorts of inputs when you don't even realize is that you are getting adjusted to this new practice world very, very quickly. So I felt that was really a very unique experience to come in that way.
Oh, that's great. So, what was your advanced masters in? I mean, did you all have subjects like we had back here, like musculoskeletal and cardiopulmonary, and so we have these
Correct.
specialities?
Yes, I had decided to specialize in cardiopulmonary physical therapy. So that was the thing that excited me the most. And my advisor was also somebody that was his specialty. And I loved chest PT at the time. But of course, now I know that it's much more than just chest PT. We started with cardiac rehab, pulmonary rehab, so many of those things. And my master's thesis was based on actually an amputee, and we did a case study. But what we looked at was how his different prosthetic feet had an impact on his cardiovascular system, which was more efficient in terms of his overall utilization of energy. So it wasn't based on just his, individual prosthetic component or individual prosthetic performance, but how did it affect his overall function?
The
That
energy
was assessed.
consumption. So it's
That was
basically the
assessed
energy
through
consumption of the prosthesis. Oh, that's interesting.
through the overall energy consumption of the prosthesis. I was also a graduate student advisor at that time and a research assistant. So I did a lot of whatever studies were going on in my advisor's lab. I was the person that was running all those.
Wow.
It was really a very fun experience. We got to assess the University of Iowa football team for body composition analysis. We did the University of Iowa women's gymnastics team for body composition analysis, and also their energy consumption. So it was a very exciting research-wise, hands-on kind of a time.
That's interesting. So this was for 2 years, or was it more?
Yes,
it was 2 years.
It was a full 2 years, yeah, from September to 2 years later, August. So
and you did your doctorate in physical therapy much later, I think.
Yes,
that was
that's
sometime
right.
in 2012 or something, if I'm not
Yes,
mistaken.
it was much later.
Much
it was
later,
when
yes.
my younger one was actually in high school. So yeah, much later.
Okay. So, I mean, in between this, did you get married or there was still time for that as soon as you passed your master's?
Actually, when I reached University of Iowa, I met this young man that you're seeing in the picture,
Okay.
and we got married right away. So
Okay.
it was very quick for me, and um, I got lucky. He was also from India. He was doing his graduate studies also in business. So
Oh,
it was really a wonderful thing. We lived in Iowa City for a few years. I started working. And then we both moved to Sydney.
yeah.
So we moved to Sydney, Australia.
Yeah. So tell us something about your experience there.
Sydney is just one of the most gorgeous cities in the world. There's anyone will tell you who has traveled there. It is just simply amazing. The weather is fantastic. They boast that they have over 200 days of sunshine a year. It's probably true, or maybe 300. I don't even remember what that number is, but it sure feels like the weather is perfect all the time.
Mm-hmm.
But the practice of PT was similar to what we had learned at GS. It's
Okay.
quite different in the US.
Mm-hmm.
It was quite similar to the Indian context. It's
Mm-hmm.
hard to get licensed in Australia,
Mm-hmm.
but I did go through that whole process and I got licensed.
Mm-hmm.
And I got a job as an assistant professor at the University of Sydney teaching. So that was a lot of fun because I had done the research masters and I had prepared myself. I was helping my advisor teach as well as a graduate student assistant, so that I felt prepared for this job as a professor. And the class in Sydney was the entry level. At that time it was a bachelor's degree, and about 150 students enter in the class, so it was a very big class.
Oh, that was a very
uh,
huge number.
Very big class. And
Yeah.
you'd have a lecture format, and
Mm-hmm.
then there'd be a tutorial format. So a lot of
Mm-hmm.
the hands-on teaching and the clinical related teaching was done in a tutorial, which was a group of 15 odd people, and then the lecture was the whole class in a big lecture theater. So
Right.
obviously I did both. I was on the cardiopulmonary team. My colleagues were really wonderful. And it was a very lovely group of people to work with. We taught sort of in the same format because, again, like I said, it was a bachelor's degree, which was similar to what it is in India. And we had, all the different subjects like we had in India too. I was also helping on the kinesiology team, and
Mm-hmm.
helping with just the research teaching as well. But basically, my core team was the cardio.
So after how many years in the US did you move to Sydney?
4 years in the US, 5 years in Sydney.
Oh, okay. So I think pretty much just after passing out your master's, maybe you must have worked for a couple of years before you moved to Sydney.
Yes, I worked for a couple of years, and both places, of course, you have to get your license,
Yes, that's
which
true.
I obviously did. And
I've heard
yeah,
that the Australian the licensing is very rigorous. I mean, the procedure of getting the license, I mean, requires you to go through a lot of, I think, theory as well as practical aspect, which usually does not happen in the license exams, I guess, in the US.
that is exactly right. I mean, I had a undergrad, I had a degree from the US anyway, so I
Mhm.
was able to sit for the exam straight away. In
Okay.
Australia, uh, I I had to go through, um, you have to do written exams and you have to do vivas as well.
Yes.
So you have to actually go through. Now, but I did that. It
Mhm.
was what it was. My husband also had a job there, so I went through it. That is a significant barrier to entry,
Mhm.
but I managed to get my license, and obviously I still keep up with my license. It's still active. You have to, you know,
Okay.
complete continuing education credits, but they
Mhm.
line up with my US credits as well, so that works very well.
Oh, okay. That's good.
Yeah.
So after 5 years of kind of, I mean, did it involve, I mean, all the time you were into teaching or did you also venture into clinical?
No, I did some clinical work there too.
Mm-hmm.
And that's, I mean, my license was allowed me to do both. So I
Okay.
did that. And
Uh-huh.
yeah, it was a very very interesting experience. It kind of gives you, the ability to having this international sort of exposure to different systems. When I look back, I see that I was able to develop a lot of critical thinking, because you're working in different health systems. Actually, from top to bottom, the whole health system is different. It's different in India, it's different in the US, it's different in Australia. So it teaches you, it forces you to start thinking in a way which is very clinically focused, and develops your judgment to create a framework and then start slotting your decisions into that framework. So you're not haphazard, you start developing algorithms in your head that you then just start building and refining over time.
I think in India, you develop it more intuitively. And I guess there's a process in place for doing that in US and in Australia, I guess.
Well, to be honest, I started that journey in India, right? So I had the tools for that, and certainly the foundation for that when I left, because I felt like I said earlier, the foundation that I got, I felt very strong with. And it was about building and refining. But yes, the frameworks have to be consciously built. And both in Australia as well as in the US, they are taught that way to have and create that framework. Yeah.
Right. So then it was back to the US?
Then it was back to the US because my husband's job changed. So we came back to the US. And of course, my license was still active here. And so I started practice right away, started clinical practice initially. My kids were younger. Actually, no, sorry. I first started at Northwestern University because I went from the University of Sydney to Northwestern University. And then I also taught on the cardiopulmonary team there. And the university is downtown, and I lived in the suburbs, and my kids were little, so that commute was really very hard. So I decided to switch to a more clinical job, which was based here close to my home. So I practiced clinically in hospital systems here around where I live on the North Shore of Chicago for 10 years. That was basically only clinical work. And then around maybe it was 8 or 10 years. I'm not recollecting exactly. But one of the jobs that I got was at the Shirley Ryan Ability Lab, outpatient clinic, which was close to me. At that time, it used to be called the Rehab Institute of Chicago. And one of this picture that I had in a cycle, it's one of the events that we had to bike to work or something like that. And that's the back of the clinic where I used to work. So that was an outpatient clinic. In the hospital systems where I worked, I did a number of things because I was initially quite a generalist. There wasn't a lot of cardiopulmonary practice per se in the US. I did start pulmonary and cardiac rehab in some of the places that I worked as a part of your therapy of therapy offerings. But I did some inpatient initially, and then basically I switched to outpatient. And in outpatient, I did mostly geriatrics and ortho.
Okay. So how was that switch? I mean,
that switch was, it didn't.
But again, because of I guess our background in GS, it must have not been a very rough transition. I think you must have smoothly,
Yeah, it didn't feel like a transition, to be honest, at all. Although I had taught in cardiopulmonary, I had always kept my hand on the clinical side. So I didn't feel that, I have to start or learn or anything like that. It just, the other thing is, because in the US, you have to keep your license alive through.
I was just going to tell that,
then accordingly, I was taking the credits that I needed to stay updated with whatever I wanted to practice. So it never felt like I dropped anything or I picked up anything at all. And especially at the old RIC at Shirley Ryan Ability Lab, we used to get patients that were more complicated, that had been seen somewhere else and then came to us. So that was a very interesting practice, very, very interesting practice.
So
And it
pretty
really
much,
isn't.
I think pretty much like a US, KEM hospital of US.
I suppose you could call it that. It's America's #1 rehabilitation hospital, I think now 30 years running nonstop. And it really is an exceptional institution.
Okay. I guess you've been lucky to kind of work there, and I guess you were also in charge of the rehab services for a couple of years there.
No,
You
I was
were
never
developing programs.
Yes, I was developing programs. I was never administratively, I didn't get into the administration at all. I always stayed a clinician. But what I did do was then I switched to a research track, and that was again very interesting. Initially, I started doing that by focusing on looking at clinical outcomes. So, we made a big push at the Rehab Institute of Chicago to develop a rehab database, and it's available even now to everyone, where you have different outcome measures. So I researched these outcome measures and wrote up a report of each of them, and we used to put them up on our internal network, and then it became now an external rehaboutcomes.com. So I did begin with outcomes, and that was a very interesting, very, very interesting experience for me.
I guess from the Indian side, I guess that's something that we kind of need to enforce or kind of inculcate, I would say, about documenting the outcomes that we get, So we are a little weak with that aspect of it, because of which, even though there's a lot of work done, it doesn't get projected out there. So somewhere along we have to start getting more robust with not only our treatment techniques are up to the mark, I think, with more or less with what's going on around the globe, but I guess we need to be robust about even the way we document things, and the way we kind of collect data. So I guess if we can just get into even that practice of doing that in whatever little way we can, I think we'll be also going a long way in showing people that, yes, these are the changes we bring about. And, so you have worked, I think this patient that is being, in the photograph, I think is a robotic exoskeleton kind of a thing, if I'm not mistaken.
Yes, it is an exoskeleton. And before I go there, I just wanted to address your, issue about documentation. So for us in the US, certainly, it's an imperative. Insurance requires it, and Medicare requires it, so there is no choice. It has become integrated into practice, and when you see a patient, you choose one or two outcome measures. For example, if you see a geriatric patient, you might choose the timed up and go test along with the 6-minute walk test. I'm just giving you a general example.
Right.
So you have something to measure on the day that you saw them, on the initial eval, and then when you're discharging them, you have that, and you want to see a difference in the measures that you chose. So it's important for you to know what the problem of the patient is and which outcome measure you're going to measure, because you're going to choose, so that you can track their progress across this treatment, sessions that you're going across their treatment sessions. So that is completely integrated. And yes, obviously, even if you don't have the insurance imperative to just do that as a matter of practice, it does several things. It improves your own performance as a PT, because then you see whether you are making a change or not. I mean, it's something that you will observe. Number two, externally, people will start to see and take you more seriously as an individual, number one, and number two, as a profession, that you are doing this in a scientific, evidence-based way.
Exactly.
And number three, for the patient themselves, they themselves are seeing that, yeah, I was doing X and now I'm doing Y. If you're doing the Berg balance test, patients will see, oh yeah, I couldn't bend down and pick up that pen, but now I can do that. So, this is something also to convince the patient to buy into your treatment. So there are several benefits. And of course, the reason that you document is then, to make sure that this is actually happening. So yeah, now coming to this picture, as I said, when I took the research focus, I was very involved in a lab that was set up for outcome measures for rehabilitation. And really, we focused a lot on rehab technology. So, for example, we looked at some amputation from some below knee prosthesis as technology. We also looked at exoskeletons, and that was a very, very exciting project. So this lady here is a spinal cord injured patient who was, I think, T2. So she couldn't stand, obviously. She was wheelchair bound. But this exoskeleton, there are a couple in the market. This particular one was developed by, you know, actually for military use, but then adapted for patients. And it has a little, it's almost like a backpack. You can see the straps.
Yes.
And that is where the computer lives. On your back. It's very light, though. Like I said, it feels like a backpack. And the crutches that go with it are electronically timed and can, work with, it's kind of like a Nintendo holder that I'm holding in my hand to help operate. Yeah.
Okay.
And so, everything is electronically timed to help the patient move in a certain way. And the patient has to get used to moving her crutches in coordination with
the lower limb.
Yeah. So it's obviously not technically locomotion, but it's simulation of locomotion.
Right.
Just the pleasure of being up.
Exactly.
I mean, I used to, when we got patients up in this device, usually most of them were crying because we don't realize how important it is to just interact with people at the level that you are in standing, where people who are not in a wheelchair, we just take it for granted. But somebody who's in a wheelchair all the time, that's just not the case. So even that experience of just being upright and looking somebody in the eye was amazing. And getting them to use this exciting new technology was amazing.
Wow. I mean, that must have been really exciting. And I guess that's what. So the technology to come down to India, I think, can be kind of usual place or normal. I think would take us some time. But it's exciting to see that you've already worked with these technologies. And I guess that's what happens. I guess in hospitals, there, even whatever technology is entering into the market, is first tested on many of these rehab centers first to see whether it's going to be valid, viable, and something which can kind of create that difference, and then it is kind of put out there into the market, to kind of be more commercially used by other patients as well. So I guess this process also must have been very exciting to kind of work with these newer prostheses for the amputees, many microprocessor kind of knee joints, and all these exoskeleton kind of devices. I think that also must have been the most exciting period. I guess your research into the outcomes of all these equipments or this tech-based rehab, which is usually a little far from us. All right. So yeah, it was exciting to see that, even this technology can someday hopefully reach commonplace. Yeah, that's the word I was looking at, So I hope it becomes commonplace, something which is more affordable, at least the rehab centers, where we can kind of make this difference. I know of a very few centers in India which have kind of got this robotic exoskeletons, but they are really few and far in between. So yeah, it's not yet become very commonplace right here. So moving on, I think after this Shirley Ability Lab, I think you worked in few more places in the US before you kind of.
Yeah, so Shirley Ryan Ability Lab was the most recent place that I worked. But as I said, I worked in inpatient and outpatient, and also what we call inpatient, rehab. So people who come from a total hip or a total knee, and they need more intensive care, but they can't go down yet to a skilled nursing facility. So,
Uh-huh.
that's a kind of a place,
So
or
it's
somebody.
so it's kind of a subacute care
It
setup.
is exactly. It's a
Okay.
subacute rehab facility. So I've worked in
Okay.
that. So I've really worked basically in pretty much every setting. I haven't done peds since I left KEM, but pretty much every other sort of facility and different kind of areas I have worked in.
So
Yeah.
during this time was the time that you did your doctorate in physical
Yes.
therapy?
Yes. At this time is when I did my doctorate in physical therapy. And, that was also a wonderful experience. I think it's important for the profession to have that visibility, and, that people have confidence that this profession has developed to the point where everybody practicing now is a doctorate. Yeah.
I guess, yeah. I think in the US, at least, I think the DPT has become like a norm. In fact,
Yes. It's
very
the
often we see
it's the
many
entry
of
level degree.
exactly.
Yeah.
So, in fact,
Now
many
there
people
aren't,
who, yeah, they
yeah,
aren't
there aren't
the
any
ones who are
master's
not.
degree.
Yeah. In fact,
Yeah.
you are kind of guided even by the places of work to kind of get it done. If you're just a master's or something from some other country, you are kind
Yeah.
of encouraged to kind of, finish your credits and, get a DPT degree as
Yeah.
soon as possible. So as to kind of,
Yeah. I think,
continue.
if I'm not mistaken, the APTA had suggested that everybody should have a DPT by 2020. So that
Okay.
was although that was probably 20 years ago. So,
Okay.
but now all the entry level programs are all doctorate entry level programs.
Right, right, right. But that's
Meaning,
not similar to a PhD, right? I mean, you
no,
come out as a
that's not a,
specialized.
yeah, it's not a research based degree. It's a
Mhm.
DPT. Yeah, it's a
Okay,
professional doctorate.
okay. So I guess the time has now come when we are kind of going to go into the path which is really very differently traveled by Gayatri, and that's being the founder of this Sundar Foundation. And I think I'll kind of let you talk all about it because I guess you being the person and the passion behind this whole thing, I guess you'll be doing justice to this.
Thank you, Sona. Yes, when I was at Shirley Ryan Ability Lab, when I started there so many years ago, I felt like this is the most amazing place to work at as a PT. And it truly was. It's an exceptional environment, exceptional people. The way they have built it, it's really wonderful. And I felt that my PT career had given me a lot of fulfillment. I had seen so many different things, met with so many different professionals and patients, and from all walks of life, but also in different forms, right? As a teacher, as a clinician, as a researcher. The other wonderful thing about being a PT when I was a PT practicing full time was that it worked with my home life as well. I was
Mhm.
always able to adjust what I was working to what my home life needed to be. So
Mhm.
it really was a very fulfilling career. And I started to feel that now I could think about another chapter.
Mhm.
I think working as a PT had always given me a lot of sort of fulfillment, as I said, and energy and joy to be with patients,
Mhm.
to make a difference in their lives. And I felt now the time had come to do that on a bigger scale, and be, if I could do that again connected to India, that would have been the ideal scenario. So I started looking around, probably, or started churning in my head, probably in 2015 or 2016. I was still working as a PT at the time, but I came to visit my mom in India. And, her Bai's child, when I was visiting, fell down and he had a concussion and a skull fracture. So she, as you have to pay for these diagnostics and everything first. Now, she didn't have the cash reserves or a credit card for that matter to immediately go out and pay for it. And that experience stayed with me, that she wanted to take care of her kid. I mean, luckily, she was able to approach people like my mother and some other houses that she worked in. And some people either gave her an advance or My mom just said, here, take this money. And she was able to get, that kid. And now all these years later, he's 100% fine. But that particular incident just stayed with me. And then I started formally looking around for some sort of environment where I could study or learn this, by working through something. And I came across the University of Chicago's Polsky Exchange. They are a place really where businesses can come together and learn. Small businesses can come and learn how the business of how to start a business, a small business, I should say. So I, at that time, they had a program for an incubator. They don't have that anymore, but in 2017, I got into that incubator program. And they have about, 10, 15 companies that they get into their incubator program. So I got in, I was the only nonprofit. Do you get everything I'm saying so far, or should I stop and slow down?
No.
Yeah. So I got into the incubator program, and it was so interesting because, first of all, as a PT, I had zero business experience. This is one thing that in our field, if you want to start your own practice, there is a business practice in under the APTA, but I had never done that. So I was always, technical and focused on the actual work of PT.
Right.
So much so that when I got into this incubator, we used to have presentations about what the status of our project was. And for the first few times, I was literally Googling things they were saying because I didn't know what. It was like learning a whole new language. And it's completely different from PT. It's not only different from PT, it's a whole different world of business. I wanted to do something that was very professionally run, not just a, time pass kind of project. So that helped a lot. And I got started from there. I developed the idea of the Sundar Foundation, made sure I decided it was going to be a nonprofit. I had to apply for the nonprofit status. And that we got in August of 2018. And actually on Independence Day 2018, we opened our, turned on our website, and we started collecting donations on that day. So what the Sundar Foundation does is we provide direct cash grants to India's working poor when they have a medical emergency.
Okay. I think there's a photograph besides this. So I guess it's based on, the Sundar Foundation is kind of taking its name from someone you know.
Yes, this is my Sundra Bai, and my foundation is in her honor because she came into our home before I was born. So when I was there, Sundra was already part of the family. Mm-hmm. And she was a widow. Mm-hmm. So she didn't have any children of her own. And my brother and I became like her children. She was very much a family member. Everybody knew her. You know how it is in India. They embraced us. She embraced us like her family. And we were, I just loved her to pieces. So I want to help people like her in that demographic that don't have any savings, but need to get to a doctor, because we believe that everyone has the right to see a doctor.
Yes, that's what is the next slide about. And I guess this kind of explains the process that is kind of followed in Sundra.
Yeah, absolutely. So, one thing is our theory of change is very much predicated on a systems-led intervention. What I mean by that is we believe that there are fabulous organizations in India. Mm-hmm. We want to work with them and actually magnify their work.
Okay.
I don't need to recreate the wheel and have a whole separate entity in India, because people who are there are doing the work, they're boots on the ground. They actually have the expertise more than I ever will, because I live here. They are there doing the work. They're holding everybody's hand on a daily basis. So it makes sense for me to, get that expertise in my corner and ask them what are their needs rather than wagging my finger and saying, you need to do this. I ask them what are their needs. And then we can work through the criteria based on the fact that our mission is to get healthcare access. We work through that and see what exactly can fit into their needs and our mission.
Right.
And that way we can work with many different partners in many different fields. So we have education partners, we have, hospital blood cancer, we work with TB organizations, we work with organizations that help young women and adolescent girls. So it's really flexible in that sense, but our mission remains the same.
Okay, yeah, because I did notice that, I think I'll come to that a little later, because during the COVID times, you'll also switch gears to kind of help children get that, some online access to education. But anyway, we'll come. I guess this small picture sums it up, like Sundar Foundation teaming up with the Indian NGO and,
exactly
providing them with the funds that would be needed on a case-to-case basis, and depending on what should be the priority of sending the funds to, I think,
yes,
and
what are the criteria? Absolutely.
Criteria. Yeah,
absolutely.
So I guess you'll have an
the
entire
other wonderful thing about our team is because I was incubated at the University of Chicago, I can get University of Chicago students as interns, and actually they're the ones who really help me run my organization. And what's fabulous about that is, students are obviously a different generation. They bring so much energy. They know things that I don't know, and they have a different take on looking at this problem. So they just give me a lot of it's an electric charge to work with young people. It feels like there's a lot of interchange of ideas that are different, and I hope that I'm mentoring a new generation of social change leaders. This young man has actually now graduated. This year in June of 2021 he graduated. He was our first batch of students that graduated.
So they did come down to India with you? I mean,
this was at a Diwali function, actually. A community event. This was at a community event in Chicago.
Okay.
I would have loved for them to come to India, but by the time that we have gotten to in 2020 would have been the right time for us to do that. And of course, now that's really put on hold indefinitely.
Yes.
Yeah, our plan was to get some folks to India in 2020. These are some of our partners in India, and we work with a blood cancer organization. So the nice thing about that is, even though blood cancer is such a big expense, what we do is we help them get into the hospital. So just that initial chemo, initial antibiotics, they get into the hospital, but then that buys them time to get their certificates from their village, and income certificate, and whatever other certificates that local donors need. I work on social workers and doctors. If the doctor says there's a medical need, the social worker says there is a financial need, and then the patient is committed to staying for the treatment, we say, yeah, go for it. We are going to, agree that your decisions, I'm basing that on your decisions, and the money is urgently needed. I don't want them to have to contact me because of a time difference. I don't want paperwork to delay this or slow it down. So based on those criteria for this organization, the money is given.
Okay.
And then that translates to, a whole year later on, because they contact local organizations and can get more donations. But basically they get admission straight away.
Okay. I guess it just speeds up the process and cuts down the red tapeism.
That's one thing, but it gives them access to the hospital at a time when they don't have money. That's the biggest thing. The point is that we're not slowing down, but in blood cancer, that is life and death, because they don't have that much time because the infection is overwhelming them. So they enter the hospital, when they, really have to be in a hospital, getting the antibiotics, getting the blood cancer chemo. Yeah. And I also just wanted to make sure that there's no confusion about one of our partners during COVID. We did not give any digital access per se. We were continuing that organization. Actually, it's Teach for India.
Was working on
was working on digital access. We continue to help their children get medicines and get healthcare access.
Okay. Because I saw that in the page and I thought maybe you all provided the tablets or the things.
No.
So Teach for India was doing that. Yeah.
Yes, Teach for India is doing that. So that's not part of our mission. And our mission is focused solely on healthcare.
Okay.
But, if a child isn't in the classroom because they're sick, they can't get their education. Their education is interrupted. So obviously, healthcare is a huge portion of the whole wellness of the child.
Right. So this is, I guess, in a classroom in a government school in India.
So we work with organizations that are in government schools, and this is when I was seeing some of these young women.
Okay.
And there's another little grantee. He's showing me his dinosaurs. He loved to draw dinosaurs. Now this is pre-COVID. I think this is in March of 2019. Yeah, so I went to his school. And he looked so well here, but when he had come out of the hospital, he was really very thin. He had a very bad pneumonia, and as a result of the pneumonia, he got an acute renal failure as well. The infection just overwhelmed his little body, but he stayed in the hospital, and we funded that. And during COVID, kids like him needed to continue with the medication, but their parents lost their jobs. So sometimes their parents are these are people who are daily wage earners. They could be rickshaw drivers, they could be maids, they could be cooks, and all that was completely closed in the first lockdown, especially.
Right.
But his medication obviously had to continue because he still wasn't 100% well. So there were other children, but his teacher was amazing, and the teacher contacted me and said, "Look, the parents are not able to support him with his medications. Could you do that?" So that is something different that we did during COVID with medicine supply, which we normally, wouldn't have done. So this is the same young man.
Yeah.
Same young man. See how skinny he is here.
Yes.
This is literally, he had just come home from the hospital. And the previous one was when he was all well and back to school.
Okay.
Same kid.
That's the same kid. Oh my, I can't believe that.
Yes. Yes, it was really nice. His parents are amazing. They're really amazing advocates. And they were really pushing for him, with his teacher, making sure that he was getting his homework, doing it at home. It was really, really amazing to work with this family.
Good. I guess this is
some
leukemia.
More. Leukemia Lymphoma Foundation social workers.
Okay.
Yeah.
And I guess
this is another young girl.
Okay. I think she was there in the previous photograph in the government school, I guess.
No, that was a different
school. No, that's a different one. Okay.
This is also, she had a really bad knee fracture. She had to actually have an external fixation. So she was out of school for 3 months.
Okay.
But she came back, did really well in her SSC, and now is in junior college. So she's really doing well.
Okay.
Yeah.
I think you have many such happy endings and happy stories. Yeah. I guess this is one more grantee, I guess, had a femur fracture, and you'll help to fund the surgery and the implant which is needed.
Yeah. So, in a government hospital in India, the surgery is free and the hospital is free. But in her case, for example, she had to pay for 50,000, or her father had to pay for 50,000 rupees for all the hardware. And there was no way she could have afforded that for the x-rays and all the other expenses, medications. It was something around 48,000. So, it was, that was a large expense, which her father could not have borne. And she's back also studying. Hopefully she'll graduate from college in the next year and a half. And
that's great. I guess this was, I guess you were trying to kind of explain how you all kind of did it even during the COVID times, if I'm not mistaken, or yeah, right.
Yes. So
Isn't it?
for
Yeah.
COVID, actually, for COVID, the new things that we did was adding medicine support, which we normally hadn't done before, and giving food rations for food insufficiency. So we gave quite a lot of, money to people who we were giving food rations to weekly.
Mm-hmm.
And it was really, you know, the response from the community was that the Indian community was that the NGOs needed support because their constituents needed the support. And then from the US, the community here also realized when things were bad across the world that we were able to do some fundraising and generate some funds to help our NGO partners in India.
Great.
So
And
yeah, it's going on. But
I
I
guess,
really
yeah,
appreciate this opportunity to talk about all this. Thank you, Sona.
yeah, no. In fact, this is really a road less traveled that I'm kind of looking at. And it's really been something amazing that you are doing out there in whatever little way. Wouldn't say, in fact, a little way. It's a big way, because not all of us venture into looking into, the need of the community, even though we do it at our level of working in
Yes.
some municipal hospital, or, going there with our students, or having some attachments with primary health centers out there. But really reaching out, I mean, taking into consideration the volume of population that is in India, and the amount of people who are out there who are needing, this help on a day-to-day basis, or at least during very I mean, I think at any given day there might be thousands and thousands of patients who are really waiting for an opportunity of a donor who can come their way and help them to kind of sort these things out. And I guess the crunch which has come due to many people losing their jobs has affected medical care very adversely in India. And
Yes.
there are not many statistics out there, but I'm sure it's a huge, this lacunae of medical care, which is kind of reaching the right people, or maybe due to crunch of it, that they are not able to reach out, or get the
Yes.
attention that they need, is really huge. And I guess you're kind of one of those wheels in the this thing which is helping the whole transition and the whole process of getting funds to the people very easily. So for all our viewers out there, I think please take this into, and if you all have any donations in any little way, that I guess it starts from very small amount and it can go on to whatever amount that you all want to, and it's a registered organization. So please go ahead and think about the Sundar Foundation for helping out for the medical care to each and every individual out there, especially in our country, right here. So now, kind of moving a little away from there, and I think I'll kind of edging towards the end of the interview. I do see that in your publications, in the peer reviewed, you've tested the C leg, all right, or very new microprocessor knee device in the US for kind of comparing it with some conventional or older knee in an amputee. So there were a few studies that you've done in that. And I guess you've also kind of done a very interesting study on translating evidence into clinical practice. So that's been your 2012 publication. So I guess I leave it open to you about whether you want to speak a few words.
Okay. So regarding the research that I had done for the microprocessor knee, it was a study that I had done some time ago, and we really looked at the differences, a couple of different things. We looked at whether using a GPS sensor could help us track their movements in the community better to determine which knee would be better. So we compared the knees that they came in with, whatever they were, and switched them out with the C-leg microprocessor knee. So those were the two comparisons, and we used different outcome measures. So one was GPS. Were they able to go out into the community, like go to shopping, go to the grocery store, do all that better with one knee versus the other? What were their actual physiotherapy outcomes on these knees? What was the overall, feeling of ease of use and functionality for these different knees. So it was a very, very interesting study, and basically the bottom line is that yes, microprocessor knees are better. They are functionally a little bit better, but it has many ifs and buts, because the person who's using it has to also be, fit, has to be able to
Okay.
be well enough to utilize the functions of that knee. That's the overall takeaway, that it is definitely functionally better, but you almost have to lift your game to get the best of that knee.
Right. And about the study which was translating.
Yeah, that is, we talked about it a little bit, and that really something very close to my heart, because, unless you have made a difference, what's the point, right? It's not about milking the patient for money. It's about changing something in their lives.
Right.
And you can only know if there has been change if you have a 0 level assessment and an assessment at some point after.
Right.
So, there's two concepts here. One is the minimum clinical difference, which is the statistically significant difference in the measure that you are using.
Right.
And the other one is the minimal clinically important difference. So even though it doesn't measure statistically, there is enough of a change that the patient or the clinician sees a difference in whatever function you are working towards, whether it's walking or whatever it may be.
Right.
Now, what we had set up is we researched several different outcome measures and wrote up a whole, we wrote up all about it, how the test is conducted, who it is used in, what's the right population, what were the different studies, what had they looked at, and then what was the MCID, what was the MCD for that, and how to, where to go and read up more about it. So we had written all these reports for various different outcome measures. And that really, to be honest, got me started on my whole research journey to say, yeah, we really need to look at this in depth to make sure that we project the work that we are doing in the best way possible for our patients.
Thanks. That's really great. I mean, the volume of data that you must have gone through while you were reading all those reports for knowing the MCID as well as the MCD must have been enormous. But anyway,
it was enormous. But it was over a period of time. And, we did it as a team. I wasn't the only one doing it. We did it as a team. So that was really, I felt, something wonderful that we had done.
Great. So now that we are inching towards almost the end, and we see that you have kind of diversified right from physiotherapy, clinical to teaching, to back to clinical, and then now kind of, taking a very different path and going into this charity non-profitable organization. I guess you are kind of had a very holistic development, I guess, as an individual. And I guess that will kind of give you much inner happiness and warmth that I think will stay with you. And you can be sure that it's going to do wonderful effects. I mean, someone who believes in karma and, the whole Indian thought process behind it, I think you're gathering a lot of good karma.
Thank you so much for your warm words, Sona. Thank you.
So any last words that you would like to kind of give to the budding therapists out there?
Yeah. Thank you for even asking me that. That's very kind of you. I think the biggest thing, of course, is, to advocate for our profession, for physical therapy, for physiotherapy. I think we ourselves have to advocate that we have this depth of knowledge, we have this unique role, and we have a certain position that helps us to help our patients be the best that they can be. I think that's the thrust of what we have to project to the world, to everybody that works with us. I think it begins with good communication. So communicate with the doctors around you, with other therapists, with other surgeons and the nurses, and everyone taking care, and all the stakeholders around, family members. So communication is a huge part of it. I think updating your own knowledge is very, very important, because if you don't do that, we can't be stuck. I mean, imagine if we had been stuck with what was taught in the 80s and the 90s when we graduated.
Right.
That knowledge is being updated at such a quick pace that you have to stay updated, and you have to be as updated when you finish working at the end of your career as you were when you started working. And what that does too, as I spoke, is it helps you, as I talked about a little bit earlier, is it helps you become a master clinician. And there's a little bit of a story about that. So I was reading for teaching about master clinicians, and there was a story about a fire chief. He goes into this burning house, and his team members are working there, and he enters a room and he tells the team members, you need to get out right now. And he's the boss. They don't ask, they leave. They all leave, and as soon as they get out, the house collapses. So afterwards, somebody asks him, well, what is it that you saw? What is it? He said, as soon as I entered the room, I felt it. And that's the word, I felt it. But I told my people I have to act. But the minute I come out here, it's not, as you said, an intuition. It's something that was developed. So he said, when I got there, I realized that the temperature of the fire and the behavior of the fire was different from what we were expecting it to be. And his experience just went through all those algorithms at a super fast pace that it felt like intuition, but it was really having pulled together knowledge and experience that makes that split-second decision look like it's magic. And he said, that's when I just told them, you have to react now, because something was not right. And he could figure that out. As a master clinician, that's what you want to end up doing. You want to end up at a point where it feels intuitive to somebody that walks into the room, but it's all your hard work. It's the mistakes that you made, but the mistakes that you went back and assessed. So to not make mistakes is not possible. The point is to not repeat the mistake, number one, and to understand and learn from that mistake. What did I do in that situation? Why did I do it? And what can I do differently next time? So you're building this experience, but you're also, as I said, building those frameworks with you. So you carry them around and, of course, share. Be a mentor to people around you, for the ones who are older and who have these frameworks set up already. And I think finally, stay curious. Stay curious about everything around you, and you never know where that will lead you.
Yeah. So the famous words, stay hungry, stay foolish. So stay
Yes,
curious
absolutely.
also.
Absolutely.
So yeah, so ending this very, very interesting journey, and I think we can go on and on, but I guess we have a time for limit to whatever, and we have kind of crossed it very wee bit. But I guess the whole journey has been so interesting that I didn't realize that we have already overshot the time. So
Yeah.
Gayatri, it's been a wonderful time just chatting up and knowing all that you've done, the volume of work that you've done, and this very new fledgling, and this baby that you've kind of started, and it's growing into a very, very fine organization too. So Godspeed and all the very best to Sundar Foundation, all the very best that it grows into something much more, and gives you a much more fulfilling experience in the future. And I hope your tribe increases. So
Thank you.
yeah,
Thank you.
yeah. So on
That's
that note,
very sweet of you, Sona. Thank
yeah.
you. And I wish you and all your PT viewers all the very best. Thank you
Thanks.
so much.
Yeah, thanks,
Okay.
Gayatri, and you're signing off. Yeah, bye-bye.
Okay. Thanks a lot. Bye.
And from all of us at Physio TV and the whole family, as well as our chairman, Dr. Parag Sancheti, and our executive director, Mrs. Manisha Sangvi, and the entire Physio TV team, the technical support by Dr. Tushar and Dr. Manish, and the rest of the Physio TV family, here's bye and good night, and Shabba Khair to all of you all. So on that note, and a very happy Diwali. Yeah, it's just around the corner.
Happy
A happy
Diwali.
Diwali to you too. Yeah. Bye-bye. Good
Bye.
night.
Good night.